That will be the main difference. In addition to that, you have secondary lesions in dermatological diseases that are related to the damage that produces on the skin, the disease process. For example, if you have pruritus and now you start scratching, that produces excoriation. That would be a secondary lesion, okay? The scales that any dermatological condition can produce, the scaling of, the scaling process, that will be a secondary lesion. Do you understand? Yes or no?
Yes.
Yeah.
Okay. So for example, let me give you examples of macules. I told you freckles, any mole that is less than 1 centimeter, right? A papule, since a papule is raised, the papule can be completely solid, like the same mole, but a little bit raised, okay? Or like a verruca will be a papule, okay? But the papules also can contain fluid. A vesicle will be a papule. Have you seen a vesicle from herpes simplex? That's a papule, okay? If it's bigger than 1 centimeter, will be mostly a plaque, and that will be a blister or a bulla.
So, wait. So with fluid is called, if you have a fluid.
It's a papule, but it's a vesicle, all right?
That's an example of
Correct, correct.
So vesicle.
Now, when it contains fluid, it's still the papule because it meets the characteristics. It's round, it's raised, it's less than 1 centimeter, but it's full of fluid, so it's a vesicle, but still a primary disease. Now, when you break that vesicle, imagine now that you're breaking that vesicle, the drainage of it, okay, will be a secondary lesion. If you start scratching and you produce excoriations on the skin, that will be a secondary lesion. Do you understand?
So like when vesicle pops, it's
Correct. Now, if the vesicle, since remember the vesicle, the criteria is less than 1 centimeter. When it's more than 1 centimeter, will be bigger, right? So that will be a blister or bulla, even though it's still a primary lesion.
So a plaque with fluid will be.
Now imagine that you have one vesicle, is the primary lesion, right? And that will be a papule because it's less than 1 centimeter. But what about if you have multiple vesicles that coalesce and form not only a bulla or a blister, but when it pops out, it produces drainage, which is a secondary lesion, yes? Okay? But at the same time, it produces a plaque. Okay, with that, thank you. So, that's the vesicle, right? Less than 1 centimeter, round, raised. You touch, and it has an elevation, right? But if you now have multiple vesicles, which, remember that, herpes simplex, you have like a conglomeration of vesicles, right? Not as big as this, but just imagine that a patient now comes with a lesion, burn, for example. You have a burn, and when you have a second degree burn or more, you have blisters, right? But the blister, the difference of the blister with the vesicle is less than 1 centimeter, the blister is bigger, right? Now, let's put multiple vesicles together, like in herpes simplex, or let's put multiple blisters together, like in a patient that is burned. When you break the walls of those blisters or vesicles, what's left over? That will be a plaque. That's another lesion, which is primary lesion. I'll show you some examples when we go through disease process. Okay?
So it's just the
So,
essence of
if you look at this patient, right here, what would you describe that? It's a papule. It's a papule. When you actually see that some of those papules are full of fluid, in this case, would be basically purulent, because the impetigo is described as multiple papules with or without honey color crossed, which are crossed will be a secondary lesion, because that will be the vesicle, most likely with purulent material inside, that broke and dried. The dryness of the secretion would be crusting, and that crusting is the secondary lesion. In other words, guys, when the lesions are intact, are primaries. When the lesions break, coalesce, are secondaries. Lesions aggregated to the skin or added to the skin as consequences of symptoms are what? Secondary lesions, which in this case will be excoriation, right? But when you continue scratching and scratching and scratching, the skin is going to compensate, right? When you use the same shoe over and over and over and over, you have a redness first, right? Which, if the redness is very small, will be macule. If the redness is very big, will be what? A plaque, right? If you continue using it, you're gonna get a blister, which is a primary lesion, full of fluid, is a papule as well, right? But if that blister breaks, first of all, you're gonna have exudate coming out, and if it gets dry, that's gonna be what? A crust, right? And if you keep using it and using it and using it, what are you gonna get? A callus. That's also a secondary lesion as a complication of the same irritation or the same inflammatory process. Do you understand? Okay. So the reason why I started like that is because it's gonna be more difficult otherwise to you to describe some dermatological lesions, right? And impetigo is characterized as multiple papules, right? With or without purulent content that when it breaks out produces a honey colored crust. Don't you see it like that? So if this is a papule, or when it's full of pus, instead of being, this gets a little bit more complicated. When it's full of fluid, transparent is a vesicle, where when it's full of pus, it's called a pustule. All right? So this would be a papule, and if it's full of pus, it's a pustule, P-U-S-T-U-L-E, right? If they start coalescing, not only this is gonna be bigger and it's a plaque, but now all those pustules broke and it's forming a crust. So this is multiple lesions in the same patients, highly characteristic of streptococci or staphylococci infection. The majority start, which is highly characteristic of impetigo, around orifices, around the mouth, around the nose, okay? Then of course, after that will spread. Okay? Now, what are the risk factors? Doesn't have to be necessarily Staphylococci aureus resistance, right, to methicillin, MRSA, but of course if the patient has MRSA, the risk factor will be higher. But most of the time, the patients do have a colonization already in the nasopharynx, and when they start having any type of viral condition and the secretions come out, what do the kids do? Not only they can have conjunctivitis, but they spread the entire infection through the entire face. Okay? So that's how it basically starts. Now, major risk factors for pediatric patients, not only is there already previous colonization of the nasopharynx, but also poor hygiene. You know, they are in daycares, in playgrounds, right? And they really don't care if they are having dirty hands with the sand or with the dirt, and they start, you know, touching their face, right? So that's why I say to be careful with playgrounds, bacteria. Okay, so this is the actual lesion that I just described. It's a cluster of, so basically they start isolated papules. Some of them can become vesicles with fluid transparent, and then they get superimposed infected with the staphylococci and streptococci pyogenes, and they become purulent, and those will be the pustules, right? They start coalescent, they break, and what you see is the dryness of the secretion of the pus getting stuck onto the lesion, like a scabby, right? And that's called crust. And that crust, because it's purulent, is honey colored. Okay? Right. Now, it could penetrate the subcutaneous tissue, and the patients can have what's basically is no more than cellulitis. Okay? But it's called ectasia. As you can see, it's exactly the same lesion, but it penetrates, it goes deeper into the subcutaneous tissue. Patients are high risk if it's around the eyes, high risk for orbital cellulitis, right? And for osteomyelitis as well, of the bone of the sinuses, okay? And you should imagine that if it's only topical, the treatment will be topical antibiotic, right? But if it goes up to the level of eczema and cellulitis, the patient has to be hospitalized and has to receive IV antibiotic, okay? So that would be common sense. Okay? So as you could see, the first line of treatment is not oral or IV. It's gonna be mostly topical, okay? So depending on how the severity of the lesions are and how is the immune system of this particular patient, you know, you can't compare a pediatric patient that has any autoimmune condition or that patient that has leukemia, for example, ALL in this population, or in an adult, any type of immunocompromised disorder compared to a normal person. You can be exposed to a pediatric patient with impetigo, you can never get it if your immune system is intact. Okay? So basically it's mucorine or bacitracin. That's the one we use the most. Be careful with polymyxin or neosporin or triple antibiotic because neomycin, many patients are allergic to neomycin. Okay? So if the lesions continue to worse, if you see that topical antibiotic treatment, the patients are not responding to it, the next step will be oral treatment. You would never hospitalize a pediatric patient or an adult patient with impetigo if it's already resolving, right? With oral or topical antibiotic. And as you could see, even though we're gonna go deeper in infectious disease, so you can at least manage the basic levels of antibiotics. When you went through pharmacology class, you had two types of penicillinase, right? Antibiotics. So you have the aminopenicillin, which are amoxicillin, ampicillin, oxacillin, etc. And you also have the cephalosporin group, right? Remember that the first generation cephalosporin, and as you advance, you start with the coverage of your gram-positive bacteria, and your gram-positive bacteria are staphylococci and streptococci. No more than that. That group does not cover, the same as aminopenicillins, they do not cover Pseudomonas. They do not cover gram-negative bacteria. Do you understand? But why would you need a higher coverage? If the only bacteria that normally lives in your skin, and after you have any type of breakage of the barrier, is the one that penetrates, what would you want to cover Pseudomonas or gram-negative bacteria if the patient is not immunocompromised?
Depends on the environment.
Of course. Because if it's an elderly patient coming from a nursing home, that will be different. Do you understand? But in regular adult, healthy adult or pediatric patient, your aminopenicillins, that includes your oxacillin, ampicillin, amoxicillin, will be enough. And if you choose a group of cephalospore in your first generation, will also be enough, right? So, for example, cephalaxin, first generation, okay? If you decide to use aminopenicillins, you don't have to combine with clavulnate, augmentin, unless the patient is immunocompromised. Or unless the patient, again, is an elderly patient that is either coming from a nursing home, or it comes from a population that is high risk for Pseudomonas, meaning that this patient is being hospitalized and admitted several times, or has been admitted in the past 90 days. Those are the conditions. Or patients that are traveling constantly outside of the country. That's another condition that you suspect Pseudomonas or gram-negative. Or if the adult is a prisoner, that would be different. Do you understand? But I can't say you and me, because we are healthcare workers that are highly exposed to gram-negative and Pseudomonas. But again, for your board examination and exit examination, any epidermal dermatological disease process, the first line bacteria that is present is Staphylococci and Streptococci gram-positive. So there's no need to start in clavulnate. You could choose amoxicillin and cefacillin. Do you understand? If you have any allergic reaction to penicillins, and remember that you have the type 1, which is anaphylaxis, then you shouldn't choose any of those. Then you have the option for is decloxacillin, okay, or clindamycin. All right? Any question? No? Any other options? For example, erythromycin can also be chosen. Now, you know from many, many, many years already that if the colonization that you have in the nose in that particular patient that has impetigo now is not sensitive to methicillin, so it's not an MSSA, it's an MRSA, which is resistance to methicillin, you're not gonna choose any type of these penicillins. You're gonna go straight to either doxy or dicloxacillin, which same group, okay, or clindam. You have the same options here in the allergic to penicillin, so why not do the same, okay? Now, vanco is too much. You wouldn't choose vancomycin or daptomycin on a patient that has MRSA with an impetigo if that patient doesn't have eczema or any type of bacteremia or septicemia. Do you understand? It's too much. If you decide to hospitalize that patient, that will be different, okay? What do you put on the nose on the patients that have MRSA? Acid tracing. So you can cover even MRSA on a patient that has impetigo with no immunocompromised disorder. That's the first line for impetigo to start with, okay? So topical, in the impetigo, acid tracing first. All right? So we talked about the cellulitis component. Cellulitis, even though you can have cellulitis or orbital cellulitis or even osteomyelitis from a patient that has impetigo, if it happens in another area that is not the face, okay, most of the time, first of all, what are the major risk factors for a patient to have cellulitis? If you have any type of fungal infection, so first, look at the nails, onychomycosis, right? Or open the toes of the patient to see if the patient has any type of fungal infection that can produce the infectious process at the level of the epidermis, right? Then, what else can produce this? Any type of peripheral vascular disease, okay? Any type of insect bite, any type of trauma. For example, we just had a patient, I worked this weekend in the ICU. We had a patient that the major history was that he was feeling short of breath. This is a patient COPD, obstructive sleep apnea patient. He was having some shortness of breath, and he felt so weak that he fell and hit the leg on the toilet. It was in the mouth, right? So he not only broke the skin, but he's a diabetic patient, which is a major risk factor, right? So of course, he didn't come to the hospital right away. He waited 3 days, and he developed an infection on the skin, right? To the point that it was so swollen that we even thought that the patient had compartment syndrome, and that's one of the major reasons why he got right in the ICU. It was septic, hypotensive, okay? So his risk factor right here will be diabetic patient, right? That they already have peripheral neuropathies and now kidney producing a lesion, trauma on the skin. He's actually immunocompromised, having diabetes. It's an autoimmune condition. So staphylococci, streptococci enter and produce cellulitis in this case. So look for the major risk factors that can produce this, okay? Now, how would you describe these lesions? So the patient has redness, right? Associated with swelling, and how do you describe that? Those are pustules. Those are pustules, right? So you see it? Okay. And of course, most likely this is associated with fungal infection. Now, remember that impetigo is the most superficial disease process of the staphylococci, streptococci in the pediatric patient, right? And when it goes into a deeper lesion into the subcutaneous tissue and the hypodermis, is ectodermal, right? It's a type of cellulitis anyways, right? But when you have it in the lower extremities or in the upper extremities, okay, and even though it is in the subcutaneous tissue, it's considered as more superficial compared to erysipelas. So erysipelas is exactly the same thing as cellulitis, but it's just deeper. And when you receive a patient with cellulitis, if the patient is not like this type of patient, that it was hypotensive and he went into rapid atrial fibrillation, most likely due to the sepsis condition, we gave IV fluids as the entire protocol sepsis that we're going to talk about in infection, okay? And the patient did not respond and had to receive vasopressor support, so he was actually in septic shock. That patient, of course, will be receiving IV antibiotic, but otherwise, if it's only a simple cellulitis, you can treat our patient with PO antibiotic, okay?
So,
Yes.
erysipelas is essentially cellulitis, only a deeper form, or more
Same
serious
thing,
form.
but it's just deeper form, okay? The same as eczema is a deeper form of hepatitis, all right? So again, we describe it as erythema. Of course, it's gonna be painful, you're gonna have swelling. If you have edema, this type of edema is spitting edema, okay? It's mostly, if it's associated with venous insufficiency, will also be pitting edema, okay? Now, in addition to that, you can have also, as we saw, some pustules associated with it, that those pustules are the one who can produce an ulcer, and the infectious process can penetrate deeper and produce an erysipelas, okay? Basically goes into the dermis, okay? So, of course, if it's in the lower extremities, you're gonna have some inguinal lymphadenopathies. If it's in the upper extremities, you can have some axillary, supra, or infraclavicular type of lymphadenopathies. patients, depending on the degree of sepsis, they're gonna have from fever, of course you're gonna have leukocytosis, of course you're gonna have elevation of inflammatory markers such as ESR and CRP, right? And again, depending on the degree of the infectious process, the patients can go into several degrees of SIRS, sepsis, severe sepsis, up to septic shock, okay? And according to that, you will treat either PO, outpatient, versus inpatient, okay? So sometimes the skin, due to the subcutaneous edema that the patients developed, and some pustules and also some blisters, the skin starts to peel off, okay? And that's why it's the reason, and also invaginates, and it looks like an orange. Have you seen the dimples of the orange? So that's why it was called a pea orange type of skin when the patients have severe cellulitis, okay? As we already said, it could be associated with blisters, it could be associated with pustules, it could even be associated with some breakage of the capillaries, producing leakage and purpures, okay? Depending again on the septic degree, that could or not affect platelets and could also affect the coagulation cascade, okay? So, elderly patients, sometimes you see the redness, you see the pustules, you see the leukocytosis or not, because remember, elderly patients do manifest completely different. They're completely atypical. Sometimes they're completely septic, and the only thing that they do manifest is changing pigmental status, like the lid. Okay? So, how do you diagnose cellulitis? It's mostly clinical, okay? You can culture some of the lesions, but there's no need unless you're suspecting any septicemia or bacteria. So, how will you start treatment? What did we choose for impetigo?
Topical.
We start topical, right? But we're not gonna treat cellulitis topically only, right? But what two options did I give you? I told you that this is most commonly staphylococci and streptococci. We still haven't moved to Pseudomonas or gram-negative unless the patient is immunocompromised. I would choose a higher option in my diabetic patient, and because he's already in septic shock, I would choose a higher option that would be third generation cephalosporin. Do you understand? Combine, yes, of course, with my vancomycin or daptomycin because the patient is diabetic, is immunocompromised. The likelihood for them to have resistance to methicillin staphylococci is higher. Okay? So, again, if I choose a penicillin in a patient with cellulitis, I would choose amoxicillin, I would choose ampicillin, I would choose oxacillin. If the patient has any type of immunocompromised condition, if outpatient and the patient is now septic, I can add now Augmentin, for example, okay? So I can have a better coverage for gram-negative, okay? If I choose a first generation cephalosporin, which again, you're a practitioner, I understand that you are concerned about the exam, but why not start with cephalexin, which is a first generation cephalosporin for all the patients? And if I start choosing any type of amoxicillin, why not choose amoxicillin to all the patients? Let's start with amoxicillin, right? 500 milligrams BO, TID, or Q8 hours for 7 to 10 days. And let's see you back in 3 days to see how you're going, follow up on you. If you choose the first generation cephalosporin, I would choose cephalexin to everybody, and then bring you back in 3 days to see how you're doing. If you're allergic to penicillin, why not start with either doxy or Clinda for everybody, right? And that would actually easier the process, okay? Any serious infection, if you ever think about any immunocompromised disorder, first of all, you have to bring this patient to the hospital, okay? And second of all, first or second generation cephalosporin will not work. You have to start now thinking about Pseudomonal coverage, which it will be third generation on. So either your Rocephin, which is your ceftriaxone, or your cefepime, which is your fourth generation cephalosporin. Do you understand? Okay. So that would be a little bit more. As you could see, if you compare this image with the erysipelas has deeper borders. Okay? It's exactly the same thing. You could have cellulitis anywhere in your body. Anywhere. If you have an insect bite in your abdomen, you can have cellulitis. If you just recently had a surgery, not only you can have a wound infection, but you could have redness associated with it, and any septicemia and bacteremia associated with it. So you can have cellulitis anywhere in your body. But if it becomes deeper, then it will be erysipelas. Okay? So as you can see, it will be more indurated, more tender, and this is the patient that has a higher risk for sepsis. Okay? And as you can see, in erysipelas, which makes sense, the deeper it goes, the more probability of complications. So if any possibility of the patient going with septicemia or bacteremia, even though you're just waiting for the blood culture's result, you're not gonna wait for that to start treatment, okay? Again, you would never miss this because if the patient at any possibility has an immunocompromised disorder that can put the patient at risk for septicemia or bacteremia or septic shock, what will you do? You will bring the patient to the hospital and start coverage already for Pseudomonas or gram-negative. And as you can see, I did not start with first generation. I already started with third generation on. Okay? So ceftriaxone, Rocephin, any possibilities of MRSA? Who's the patient, who's the population that is at high risk for MRSA? The same patient that is at high risk for Pseudomonas. So is that immunocompromised patient? Is that patient that was recently admitted and discharged in the last 90 days? Is that patient that has traveled outside the country? That patient that has been on antibiotic treatment as well in the last 90 days for any other reason? Okay? Is that patient that lives in a nursing home? That patient that is a prisoner? Right? And basically it. So the same risk factors for Pseudomonas are the risk factors for MRSA. Okay? So I would choose first Rocephin. If you have any risk factor for MRSA, you combine it with vancomycin. Another medication that can cover MRSA, daptomycin. Another medication that can cover MRSA, Zyvox. Linezolid. Okay? Those are the three choices that you have. Okay, of course, we'll start with vancomycin first, not only due to the cost, but also due to the side effects that the other medications have. All right? So if you have any type of penicillin allergies, erythromycin in the hospital, no. Even though the guidelines said that, in combination with vancomycin, what you could do is, you actually start with doxin plus vancomycin. That will be your choice. All right. So, again, we did impetigo, superficial, ectima, deeper, right? We did cellulitis, more superficial, erysipelas, deeper, all right? So now we're gonna go through some of the lesions that also can penetrate, all right? So let's start with furuncles and folliculitis, okay? So you can understand this. What is folliculitis? Folliculitis is no more than an staphylococci or streptococci infection of the bulb of the hair follicle. So basically, what you call an ingrowing hair. So that's one hair. But when you have multiple hairs that are infected as a group, okay, that will be called furuncle. So folliculitis is one. Multiple follicles infected is called furuncle, okay? That could happen by any obstruction or superimposed infection with staphylococci or streptococci in a group of follicles. Where do you have hair? Well, you could have it in the barbae, which is called Latin, so the beard, right? So if you have, whenever you shave, whenever you have hair. You have hair in your axillas, you have hair in the beard, you have hair in the nose, you have hair in the pubic area, in the anal area, in your legs, anywhere that you could shave or not, all right? So, depending on, or even in the neck, I've seen it in the neck. So, when you have one is folliculitis, that of course you treat what? First you have to take out the foreign body, which in this case will be a hair. When you shave, some hairs don't grow up straight and they basically coiled into the skin, and it's basically a foreign body for the skin, right? Because it's not part of the follicle at that time. And you basically have to remove that hair and apply topical antibiotic. It's only one, right? Now furuncle is a multiple amount, and the bigger the plaque, guys, the bigger your immunocompromised condition. So you have a major group that you're not gonna take blood one by one, right? So basically you're gonna avoid shaving on the area, first of all. So irritation has to be discontinued. And then you apply not only topical antibiotic, but you also have to give the patient oral antibiotic. We're gonna go through the treatment in a second, right? Now, in addition, these follicles that are infected could be due to, first of all, obstruction of the sweating glands, right? So if you have any type of obstruction in the sweating glands, that when you sweat the most would be in the axillas, okay, or in your genital area, that can produce hydroneck suppurative, all right? Which is no more than tell me that none of you have had sometimes like a painful nodule in your axilla that is highly produced by deodorants. Yes or no?
Yes.
Or when you shave, it obstructs and then superimposed infects. So what will you do first is, the first line of treatment is to avoid the irritation. So what produced that? Is the spray deodorant, or is the paste deodorant, or the solid deodorant? I'm not saying you're not supposed to apply deodorant, yes, you're not, but if you do, do it around the area, never directly to it, okay? And second of all, depending on how big the furuncle is, you could also drain as well, okay? So hidradenitis suppurative is no more than a furuncle that is produced in the axillary area by obstruction and superimposed infection of the hair follicles and the sweating glands. All right? That of course, what do you have in any area of the skin? Staphylococci or streptococci. Do you need a higher level of penicillin or cephalosporin? No. So you would see that the treatment is basically the same, okay? So first of all, you see tenderness, swelling, that it gets bigger and bigger as you continue to, you know, apply whatever insult produced this, the deodorant or the shaving or whatever, okay? So basically sometimes the patients do have a fluctuating abscess that you have to drain. So it's highly painful, sometimes you cannot even put your armpits down, okay? And first of all, if it's very small, like it's only one follicle, as I told you, topical, antibiotic. Now, let me compare the difference of outside sternal skin with your pubic area, your anal area, or your axillus, okay? You have two types of swelling glands. I don't know if you remember this from anatomy. You have epicrine or apocrines, okay? The epicrines, even though both are in the dermis, both of them, the epicrines do not have an outlet the epicrines do have an outlet to the skin, and that's the reason why they're highly contaminated with staphylococci and streptococci, but they have no possibility of any type of gram-negative or anaerobes. Then the apocrines, well, I learned in medical school, like those are the ones that are really fetid, okay? And where do you smell the most? In your armpits and in your genital areas, right? So therefore, the apocrine glands are highly contaminated with any minimal residuals of gram-negative and pseudomonas. And that's the reason why we never start with your bacitracin, even though it's not wrong to do it. If you apply bacitracin on the folliculitis or furuncles, okay? But we can do Clinda as an alternative treatment. Now, if you have to start PO, what will you choose in order not to confuse you? Same thing. Highly is not indicated if you have any type of folliculitis or furuncle or even hidradenitis suppurative to start oral antibiotic, because drainage of an abscess and topical antibiotic is more than enough. When in your life you needed to take oral antibiotics for any type of, how do you call this in English? Like in a common?
Axilla?
No, no, they're actual lesion.
Boils or like people put it like that.
Well, boil will be an abscess.
An abscess?
Or maybe Cuba, we have a name for everything.
Yeah.
What's the
Okay.
name in
You're saying like under the armpit?
What's the name in Spanish for us? I don't know.
We say in Cuba, golondrina.
Ah, that's right. Now I haven't heard that one.
I don't think they're really Never heard of it?
So again, guys, even though the guideline recommends, even though as you can see, the guideline recommends tetracycline family as the first line for hidradenitis suppurative, it is not wrong at all if you decide, and it's actually on examination as well, if you decide to choose the same amoxicillin, okay, the same bacitracin topical. So if you choose a topical antibiotic to start because you only have folliculitis and there's no abscess related to it, after you drain, if you decide to start topical antibiotic on a folliculitis patient, it is not wrong to start with bacitracin. Do you understand? The reason why we go a little bit higher level to Clinda is because, as I explained to you, the apocrine glands have a minimal contamination with pseudomonas and gram-negative, okay? The same way that if you decide to start oral antibiotic because now the patient has an abscess that you have to drain, it is not wrong if you choose your cephalexin. You remember that we had that as a choice? And if you have a patient that is allergic to any penicillin, then we choose doxy anyways. So you can also decide to do that, okay? So any tetracycline family, tetracycline, doxycycline, minocycline, which the one that is actually least expensive is doxy.
What if you were to have this happen chronically, let's say, several times a year, or more
Now,
than one at a time?
education is the key, because as I told you, what actually triggers these is something that is occluding the sweaty gland or any foreign body. So you're shaving and you're constantly having growing hairs. Right, so educate the patient that, for example, laser, I used to have this a lot, so I did laser and the problem was gone. And if the spray deodorant is the one that produces you that the most, try to choose others, alternate with others until you actually find one that doesn't obstruct the sweaty glands. Okay? But that's what starts the process. So you not only have to only treat, but educate the patient on how to eliminate the trigger. Okay? Now, necrotizing fasciitis. And this is exactly what we thought that this patient was brought in with. Why? Because having a trauma, having a lesion in the skin, because in reality it was only like a laceration that he had, but being a diabetic patient that is already an autoimmune condition that can put the patient in an immunocompromised disorder to be able to fight wound healing, right? Or wound infections. Patients can have a rapid spread and penetrance of the staphylococci and streptococci in this type of patient and produce destruction of the fascia, including the muscle, okay? Then I described this patient as having so much swelling in the lower extremity that we even thought that the patient had compartment syndrome because the pulses were really slow, and it wasn't related to that. There was no compartment syndrome. We did an MRI, and it was completely normal, just large amount of soft tissue swelling. But vasculature wasn't affected with the Doppler, okay? And basically, we just had to treat the septic shock that the patient had related to it, okay? So basically, as I said, this doesn't happen in patients that have a normal immune system. But any minor trauma to the skin in patients that have immunocompromised disorders can have a rapid spread of this type of gram-positive bacteria and penetrate so deeply into the fascia or subcutaneous tissue to the point that can produce necrosis. And that will be necrotizing fasciitis, okay? Now, of course, the patients will have so much pain that sometimes does not correlate the clinical findings, okay? Because you don't see it the first time as this. This is after the treatment, okay? This is after the treatment. But first of all, what you see is redness and swelling of the skin to the point that could compromise the vasculature underneath or the nerves, okay? And then the skin becomes really, really hard and so tight that, as I said, can compromise the vasculature of the skin. Now, because, again, it happens highly in patients that are immunocompromised, doesn't have to be necessarily only HIV, any autoimmune condition, okay? Like diabetes and hypothyroidism is one of those, okay? It goes into the dermis, not only bringing with them the gram-positive bacteria, but in addition to that, due to the patient being an immunocompromised host, these patients have a high risk of being contaminated with Pseudomonas and gram-negative anaerobes, all right? And so you would see highly advanced type of antibiotic in this particular patient. The only way to treat these patients, it would be, of course, bringing the patients into the hospital because the likelihood of losing a limb or to the point of having osteomyelitis is really high, okay? These patients are highly septic, okay? So you bring them into the ICU and you have to do not only debridement, which is the key of this, but also put the patient on IV antibiotic that are able to cover Pseudomonas and gram-negative anaerobes. But as you could see, always continues, number one, where you actually bring from the skin to the inside, okay? This is after the treatment. This is basically a patient that had a dental procedure and dental abscess, and even though there was drainage, produced infection to the sinuses and necrotitis fasciitis. Doesn't happen to us. We can have, I have seen it in ICU. We can have an abscess, but can you have an abscess of your maw and then molar area and then produce a necrotitis fasciitis? This patient has to have an autoimmune condition. And of course, you're gonna deal with this problem first. You have to also investigate which type of disease process this patient has. If it was already diagnosed, well, we already know. But if it hasn't been diagnosed, what type of immunocompromised disorder this patient hasn't been diagnosed from, okay? The same as when you have a patient with epidermal necrolysis or Stevens-Johnson syndrome, we can have an anaphylactic reaction or a simple rash with sulfa drugs or with penicillin, but we never go up to the point of having epidermis necrolysis or Stevens-Johnson syndrome. Do you understand? After you treat those patients properly, like a burn patient, you have to look for the underlying immunocompromised disorder these patients have. Most likely autoimmune conditions that have not been diagnosed for HIV. Okay, so as you could see, the main treatment for that will be the treatment. Okay, and of course, graft, skin graft. All right, so again, pain out of proportion, because as I said, you only see at the beginning what we saw in this patient, redness, swelling, to the point that there's compromise of the vasculature and nerves. But when you look to the outside on this particular patient, only had a laceration when he fell. Then you see necrosis, hardening of the skin, and then necrosis will start, and that at that point will be too late. Okay? So bullous, then you have, because there's superimposed anaerobic bacteria, you can have a lot of crepitus associated like a gangrene. Basically, the patient goes into gangrene just because the fact there's so much edema that compromises the vasculature that the patient loses pulses and therefore ischemia and therefore necrosis. Okay? So, of course, this patient is going to be septic. So, how will you be treating this patient? Now, even though the guideline says that the first line treatment for necrotitis fasciitis would be penicillin G, have you seen penicillin G in clinical practice? Constantly. Even for endocarditis, the number one treatment is penicillin G. Do we really use penicillin G all the time in patients that have endocarditis? We mostly choose rocephin and vancomycin, right? So, what can you choose on a patient that has necrotitis fasciitis, depending on the patient? Like, for example, we did an MRI on this patient's leg, and the patient did not have necrotitis fasciitis, but if we were suspecting necrotitis fasciitis on this patient, and even after the MRI that it was completely negative, what you be basically looking to the outside is an intact skin only with a laceration and a lot of edema. So forget that the patient was in septic shock. Imagine that it's only leukocytosis, the patient has fever, the patient has a swelling leg with a laceration. You're just suspecting that the patient can have, or it's a high risk of necrotitis fasciitis. So what will you do? It is not wrong to put the patient on rocephin and vancomycin for first line, or putting the patient on a 4th generation cephalosporin, which is cefepime with your vancomycin. Do you understand? When you're suspecting in a patient that is not in septic shock that has any anaerobic component associated with it, you can add clindamycin to the treatment. So ceftriaxone rocephin plus vancomycin plus clindamycin, or you can add cefepime plus vancomycin plus clindamycin. Now, if the patient is in septic shock, and already the patient is showing signs and symptoms of necrotitis fasciitis, like necrosis, like crepitus, you see that the skin is full of blisters, and you see the vasculature that is already compromised, there's signs of ischemia or compounded syndrome, not only you're gonna do fasciotomy and the treatment, you're gonna bring this patient to the OR, but I want you to take a look at, you can also choose what? Your meropenem, your imipenem plus vancomycin. What did I tell you in GI that we can choose whenever we're thinking about gram-negative and anaerobes? Flagellus one, isn't Clinda another one? That's the reason why I just mentioned Clinda. So let's summarize this treatment. First, there's no necrosis of the skin, there's no septic shock. You could do rocephin and vancomycin, or you could do cefepime and vancomycin. Are you suspecting that the patient has a high risk for gram-negative anaerobe bacteria? Let me add to the treatment flagell or clindamycin. Patient is not in septic shock. Patient has no necrosis. All right? So you can start with that. You receive an MRI that actually confirms that the patient has either osteomyelitis or the patient has necrosis. Not only you're bringing this patient to the OR surgical team or like right away for the treatment, because you do nothing by giving a bunch of antibiotics if you do not debride the skin. Okay? The same with an abscess. There's no penetration of antibiotics to an abscess if you do not, drain the abscess. Okay? What else can you do? The patient's already in septic shock, the patient has necrosis confirmed by clinical findings or by MRI, you can start higher up. And as you can see, the only different choice is that because you have the flagell that we mentioned, you have the Clinda that we mentioned. If you're thinking about MRSA, always is Vanco. We had it as the first choice, right? Mm-hmm. So patient is in septic shock, don't leave the patient in rocephin and Vanco only, go a higher up level because the patient already has necrosis independent. Okay? So rocephin and Vanco first, or cefepime and Vanco first. Patient has any major immunocompromised disorder that I'm suspecting gram-negative, Clinda or flagell added to the treatment. Patient has necrosis by clinical finding or by MRI, imipenem and Vanco. With imipenem, you don't have to add flagell or Clinda. Far enough. Okay? Now, you have another disease process that is called toxic shock syndrome. In the past, and many years ago, toxic shock syndrome was first discovered by the use of Tampax or tampon, left on for a long time. The same way you're supposed to change your female pad when you have your menstruation, you're supposed to change your tampon every often as well. What women used to think is that by having a tampon, I'm not going to be staining, so therefore I can leave it on for the entire day, right? So therefore there were superimposed infection. Not only, remember, I don't know if you were my student when I told you this, but one mechanism to know your bacteria is that more superficial you go, the more external you go, the more gram-positive. Mm-hmm. The more internal you go, and from the diaphragm down, the more gram-negative bacteria and anaerobes you will be exposed to. So even though your mucosa, which your vagina is a mucosa, is same structure as the epidermis, right, as the skin, is just an imagination of it, even though you still have staphylococci and streptococci, it's deeper and it's below the diaphragm. So that means that you have a component of Pseudomonas and gram-negative anaerobes. So therefore, the longer you leave the tampon in, the more damage to the skin, because remember, any barrier on the skin does not allow the skin to oxygenate properly, right? Expand properly and vascularize properly. So therefore, it will be micro damages to the mucosa and penetrance of the staphylococci and streptococci, and the deeper you go, therefore, gram-negative also will come in. So these type of bacteria are penetrating in the vasculature of the dermis, which all your vessels are, and producing septicemia. And the patients were dying from it. Okay, now what else can produce this? Well, if you have any type of residual of tissue, you can also have toxic shock syndrome. Like for example, you have some gauzes in place when you had surgery. You had some placenta left over, or any type of fetal residual after delivery. You can also have toxic shock syndrome. So there's no only related to tampons anymore. Okay? For example, leaving the female diaphragm for a long time as well can produce it. Okay? So any type of, think about any type of residual in your body. It could be natural from tissue, or it could be artificial, like sponges and gauzes and tampons and diaphragms and anything. But having also a pool of blood, like a hematoma, in your body for a long time, not only that can produce DIC, right, because it activates the coagulation cascade, but can also produce toxic shock syndrome, because again, it's any tissue left over, and your erythrocyte, your blood, is a tissue. So having a retroperitoneal hematoma or having any hematoma accumulation can also produce toxic shock syndrome. Okay? So those are the major risk factors. All right? So what else can produce this? Of course, other risk factors that can produce this is patients that have any type of sepsis due to viral conditions, for those are the ones that are reported. So how would the patient present? How any septic shock patient presents. Now the only difference is the trigger. The only difference is the trigger. So the patient would have from fever, leukocytosis or leukopenia, from fever to hypothermia. Just think about any septic patient, okay? To hemodynamic instability, to the point that you give the patient IV fluids, right? And the patient does not improve the blood pressure, and therefore you need vasopressor support, and that's the definition of shock. All right? So, what are the major complications that any septic shock patient can have? Just tell me. From depression of the ejection fraction and the cardiac output. Remember, exactly. Let's go back to the pathophysiology, and so you don't have to memorize. Whenever the patient's blood supply or perfusion to the tissue is compromised, your GI shuts down, right, to deviate the blood to the necessary organs. Your kidney also shuts down to deviate to the necessary organs. So you go into ileus, up to mesenteric ischemia. You go into acute renal failure, up to the point of renal damage, right? And what else can you have? Well, depression of the cellular metabolism, and that include the heart. So the cardiac output is compromised. Have you seen patients that come with a normal echo, and after their hospitalization with septic shock, they actually, ejection fraction is diminished, right? And that's the reason why now they start having pulmonary edema later on, and they start having anasarcas and so forth, because, and then you repeat the echo and you see that they came in with 60 and now they have 30. And that's the depletion of function of cellular metabolism due to sepsis. Okay, what else can they have? Isn't sepsis the major trigger of the inflammatory cascade? And what is adult respiratory distress syndrome? It's no more than a major inflammatory insult, right, to the alveoli, that you lose what? Surfactant, and there's massive amount of lung collapse, right, or alveolar collapse, and that's no more than ARDS. So the same complications for any septic shock can also have a patient with toxic shock syndrome. And what about liver? Isn't liver part of the splanchnic circulation, the GI tract? So not only your intestine shuts down, but everything else. Have you heard what's called liver shock? So every time the patient goes into shock, every organ that participates in the splanchnic circulation, that means belly, also can shut down. And you see the liver enzymes highly elevated, and we do nothing for that because we're expecting that once the patient major or initial insults disappears, those liver enzymes will start to decline and improve, all right? So how do you diagnose this patient with toxic shock syndrome? Well, first of all, the same way you diagnose any patient with septic shock or with sepsis. What do you do first? Cultures, right? What do you see in the CBC? Again, or leukocytosis or leukopenia. Can you see thrombocytopenia?
Yes.
First, you may see thrombocytosis, that's a reactive condition to any inflammatory process or infectious process. Then the sepsis itself starts to deplete platelets. And you see the thrombocytopenia due to sepsis. There's highly consumption of all cellular metabolism. So patients will have thrombocytopenia and bleeding, okay? That's one of the major complications as well. What can you see on the CMP? Well, you can see electrolyte imbalances that we'll see in this semester, like hypernatremia, hypokalemia, hypocalcemia, hypomagnesemia, right? Bune and creatinine elevated, you're expecting that this is pre-renal, so that's the reason why you start giving fluids to the patient that have sepsis, 30 mL per kilo all the time. And then you start knowing how you calculate for maintenance in this semester as well. And what else can you see? Again, highly elevated liver enzymes, that even if you can do lipase and amylase, is nothing to do with that, is due to the amount of tissue perfusion deviated from the liver to any other major organs, okay? So, and then you start treatment. How do you think we treat toxic shock syndrome? How do you treat any septic patient that you still don't know exactly? First, the first line is fluids, lots of fluids. Any septic patient can have a minimal deficit of 6 liters. So yes, you calculate based on kilos, like if you're 70 kilos times 3 is 21, so at least 2 liters and 100 mLs, right? That's the minimal that you start with. But you need to have in mind that there's at least 6 liters of deficit, of water deficit. And I'll help you here also this semester, how to help you with water deficit. Blood cultures, of course, yes, and antibiotic. That's the main line. And then meanwhile, you start to investigate the trigger and exactly the etiology.
And the antibiotics would be tailored to whatever the culture's.
Correct. But
Oh,
you
so
start
you start with
right,
one
like anyone. You start there. Now, if we talk about toxic shock syndrome, or if we talk about any type of sepsis, how will you start any type of sepsis that you have to start broad? That you don't know exactly if it's gram positive, if it's gram negative, if it's anaerobes. Again, why Zosine and Vanco? Because I cannot choose aminopenicillins alone, because aminopenicillins, amoxicillin, oxacillin, they only cover gram positive, right? So I can't do that. I have to combine them with tazobactam, for example, that covers gram-negative and pseudomonas, and that will be, for example, either your unacin or your Zosine. Yes?
Yes.
Then that will cover already my gram-negative and pseudomonas, but it doesn't cover MRSA just in case, right?
Banco.
So you add Vanco to it. That's if you decide to use the penicillin family. If you decide to use the cephalosporin family, what will you use? We use first and second? Never. You have to start third or fourth. And that will be third, your ceftriaxone or cefing, plus vancomycin, and or you would have to start with fourth generation cephalosporin, cefepime, which is also maxipine, the same thing, plus your vancomycin. Okay? Allergic to penicillin? Type 1? You could do, well, depend. You could do, she says, okay, let's do fluoroquinolones. It's not wrong. You could do levaquin. What do you need to know about levaquin on the patient? You need to look at your EKG first to see if there's any possibility of QT prolongation. Otherwise, you can't start. Okay? Are these patients at risk for it?
Yes.
And a lot of arrhythmias. Okay? So it's not wrong. You could do levaquin and vanco. Not wrong. But there you have two medications already that can prolong the QT. Okay? So let's go through this first. Remember that in endocarditis, you need to memorize the major and the minor criteria. Okay, so here you need to memorize the definition or criteria by CDC for toxic shock syndrome. So again, these patients would have fever. Of course, this is the most common, but many other patients will come with hypothermia. So fever. Hypotension has to be present because otherwise it wouldn't be shock, right? And this is the hypotension that doesn't resolve with IV fluids, doesn't respond to it, all right? Patients do have a rash, and this rash sometimes start with redness associated with petechia. Why petechia? Because this infectious process, what does it do to the platelets? Thrombocytopenic, right? What's due to the coagulation cascade? Remember, inflammation, complement, coagulation. So any infection or inflammation can do this. And as we already went through, what about other organs that could be affected? At least 3. Didn't we say that patients' plaque and circulation will be affected, right? So first of all, starts to slow down, and what would the patient do? Increase bowel sounds and abdominal distension, and then the patient starts vomiting, right? So GI symptoms. If it's related to muscular, okay, by having decreased tissue perfusion at the level of the muscles, the patients can have myalgias, which is suffixed for one criteria, up to the point of rhabdomyolysis that the patients have an elevation of CPK, creatine phosphokinase. Okay? If it's related to muscular membranes, it's basically what actually triggered the condition. In this case, will be the tampon or the diaphragms, or any mucopurulent discharge the patients would have. As we said, what actually is affected first is the GI tract and the kidney. So if you already have the GI tract and the kidney, and you have thrombocytopenia, you have 3 already, right? So you have the urine and creatinine elevated. Didn't we say that this patient is going to liver shock in spite of the splenic circulation? So just having LFT elevated, transaminitis, these patients don't fix the criteria. As I told you, thrombocytopenic patients, and that's the reason why they start having these lesions to start. Not only the inflammatory process or the infection produces vasodilation and redness in the entire skin, but also petechias and bleeding, okay? And most commonly, even though it could happen in any adult, elderly patients will come with altered mental status, and that's the major presentation for infectious processes. That, when you look, and this is important, when you look for sources of infection, everything else is negative. That you're thinking about upper respiratory syndrome, you do like strep cultures, and they're negative. You're thinking about your analysis because it's a UTI, and this is what actually produces the sepsis and septic shock, and everything's negative. Do you understand? And as I told you, this highly happens in patients that, for example, I'll tell you a big example that we had. 22-year-old, this is true, okay, on the weekend. 22-year-old female. She was having sex. And right after finishing sex, she developed a sharp abdominal pain. And she collapsed.
Okay.
She was brought to the hospital, and she has a history of ovarian cyst. That's the only thing. 22-year-old, physiological. That's completely physiological cyst that occurs with a cycle. And every gynecologist will tell you that it's normal practice, okay? Yeah, it's your hormones that produces that, and then they disappear with the cycle. So basically just follow up. And you know what happened? Ovarian cyst rupture. And she had a retroperitoneal hematoma. The gynecologist, which I'm not gonna mention the name, they say she came basically in the afternoon, but after I guess he was already home, and I'll see her in the morning.
Oh, yeah.
Oh yes,
Yeah.
really. Of course, she deteriorated quickly to the point that trauma surgery had to be called, and she was brought into the OR and drainage of the retroperitoneal hematoma. Okay, so in her case, it's super obvious, but if this patient, imagine that had a rupture of the ovarian cyst, and it was just a mild leak, just imagine this, the patient did not deteriorate, did not have a secret episode. Imagine that she was just having abdominal pain, and she just waited because she was okay, right? Many patients do that, and they come late to the ER. So imagine that this patient comes to the ER already with fever, right? And some hypotension, and you know that she's in shock, and you know that she's septic, and you can't find the source. That would be toxic shock syndrome. And in her case, why? Because it's bleeding in the retroperitoneal space that is a tissue. And that tissue, as a pool, as a hematoma, is the one that produced the cascade of events. Do you understand? It will be actually obvious, or more obvious, if it will be a patient that just delivered, or the patient that had a miscarriage, abortion, and you are thinking about rest of the tissues of the pregnancy left over. Do you understand? That not only the patient can have toxic shock syndrome, but the patients can also have VAC. Do you understand? You cannot find the source because everything else is negative. All right? So, for example, this could be enough to produce it, even though it's not the most common presentation. Okay? Like just having a pool of blood accumulated and an infectious process. And we went through the treatment already, right? Now, in any patient, including the toxic shock syndrome, okay, it's more expected here because you had a major insult. That the patient starts to have vasodilation and redness of the skin, right? Swelling of the skin, some petechias, and then there is major declination. So declination is peeling of the skin, okay? So this particular patients are septic, can go into another disease process, which is called epidermal necrolysis or Stevens-Johnson syndrome, or simply as a hypersensitivity reaction, okay? So you now are exposed to seafood, or you take a medication, and the most common medication that can produce this reaction is sulfa drugs, even though there are many, prokinamide, amiodarone, there are many medications, as you would see, that can produce this type of reaction. As you could imagine, Stevens-Johnson syndrome is even though it's severe, because the patients can go into shock, so much fluid that they lose, okay? But you should imagine that this is a less severe stage compared to epidermal necrolysis, okay? So basically, it's no more than a hypersensitivity reaction. That instead of having angioedema and a blockage of the upper airway, it happens at the level of the skin. Instead of having a simple rash, when you take penicillin, instead you had a major vasodilatory response in your skin, and then you start to peel off your skin, like a burn fish. You develop blisters, and then the blisters break, and you start to peel off the skin completely, which is the protector with the first barrier of entrance of any type of infection, okay? So, antiepileptics can produce it, any antibiotic can produce it, any major cytochrome medication can produce it, and I can tell you that from, as I said, amiodarone, digoxin, any antiepileptics, guanidine, as another antiepileptic that can produce it, but the most common medication that is involved in this is sulfa drugs. And as I told you, the majority of these patients have an autoimmune condition hidden or undiagnosed. That could be from HIV, which is the first you have to rule out, because there's highly implicated homocysteine venin in this type of reaction. But any other autoimmune condition can be present, okay? So you have to run a collagen panel on these patients, and I know that the 7 of you that work with Dr. Morton went through autoimmune conditions, but I have to go with my group that I couldn't finish. Well, then if you stay, you will benefit. We negotiated a little bit extra time to teach those conditions that we couldn't. Okay? All right? So as you could see, lupus. So basically the minimal that you would do is do an HIV on your patient, HIV test, and also ANA and RA, at least minimum. If those are positive, then you go up to the antibodies that we're gonna teach. Since it was part of the class, still spending. All right? So, any questions so far? So, basically, as I told you, you start with, you take the medication, sometimes you don't even remember because it's not as fast as you're expecting, like taking a penicillin and then you develop rash. Sometimes remember that in pathophysiology, we went through hypersensitivity reaction, and this, even though most commonly is 1, could be 4. That's delayed. Okay, so some patients, a week passes or 2 week passes, and then they develop the reaction and they can't correlate the exposure to sulfa, for example, with this reaction. Okay? So yes, you have diffuse erythema, as I told you, because venous hypersensitivity reaction type 1, you produce a major vasodilatory response, and then you could start having the macules, which are vesicles as well, which are blisters as well. They start to rupture. Not only to drain a lot of fluid and you have electrolyte imbalances on that patient, but then your skin dries and peels off. Okay? That's golden cold sign. Okay? That could also happen in pemphigo virus. Is another disease process. Okay? So, of course, that patients as well can have a lot of complications. Because if you have so much edema on your skin, can block your airway, can impede your saliva, right? And your no more swallowing, and you can aspirate your own secretions and have pneumonias, right? This is a septic patient that is having hypovolemia, right? And electrolyte imbalances, so they can go into acute renal failure and all the complications that any septic patients can go through. So as you can see, this is a more exaggerated presentation, but you can have, like, imagine a rash. Patient has a rash, and the rash becomes bigger and bigger, and they start to coalesce, and then you have edema and a lot of redness, and you have no idea what the heck is going on. Right? And then you're actually in shock into the hospital with a normal rash. And then you start to peel off. How you treat this patient? First of all, like a normal septic patient, and fluids, a lot of fluids, right? Protecting the airway, IV antibiotics. In addition to that, how do you treat any hypersensitivity reaction type 1? Steroids, right? You have to give at least hydrocortisone on these patients, looking for the underlying condition, and also, since the patient has so much skin peeled off, the hypodermis is exposed and infection superimposed. So you have to basically cover that skin like a burn patient, okay? So those are the issues. You see how the skin starts to peel off. Now, if the skin becomes necrotic, that will be epidermal necrolysis, which the triggers, the etiological factors are exactly the same. Okay? So as you can see, we basically went through the same thing. Look for HIV, and if the patient has HIV, not only you treat HIV, but you also have to add cyclosporin that basically triggers the CD8. You can also do immunoglobulins and plasma exchange if this patient is actually highly immunoglobulins. But that's not the normal routine that we do. Okay? So basically I think it's, 1 minute for me to leave. So we'll leave it up to here, even though we kind of have talked already about the colitis and the and all that, but I'm gonna go over it again.